Today, I am going to talk about basics of total knee replacement. Maybe in the whole year, we will cover 4 or 5 important topics of total knee replacement. We will first talk about the basics, and maybe in the next lecture, we'll talk about the commoner varus knee, and maybe in the third lecture, we'll talk about valgus knee and flexion deformity, because these are the 3 deformities we see. But first, let us understand the basics of total knee replacement. As you all know, that total knee is a bony and soft tissue operation, and quite often, people use, in the early days, are used to a sawbone workshop, so the bony component gets a lot of highlight. And there are various terms used in this surgery which are very important. But one must remember that bone and soft tissues both are there in a knee. We should not do anything extra to the bone or to the soft tissue to compensate for each other. By that I mean that if a patient has a varus deformity, which is because of soft tissue, we should be tackling soft tissue and not cutting the bone in valgus. On the other hand, if the patient has a varus deformity because of previously healed fracture or because of bowing of the bone, then we should be cutting the bone in such a fashion to correct varus deformity rather than trying to treat the soft tissue. So the important part is whosoever is the culprit, he needs to be punished, not the other person. So let us first think the basic bone cuts that are there in a total knee replacement. The femoral cut involves entry into the medullary canal. Now, the entry into the medullary canal is with the help of a drill. Quite often, people ask me, what is the best entry point? I think the best entry point is different for every patient. Go back to the X-ray viewing box, see the AP and lateral X-ray, and find out the proper midline on both the X-ray. Say suppose on this lateral X-ray, you are able to see this is the width of the bone, and take a midpoint of that and draw a line. If that line comes at this point, then this is your entry point. See the AP X-ray, see what is the width of the bone at 2 points, just draw a line from that. So idea is you are going to enter from the center of the lower end of the femur into the center of the medullary canal going towards the piriformis fossa. This is the axis of the femur entry point. A lot of the times there are osteophytes in the notch over here. Now those osteophytes one has to trim. If you probably ignore the osteophytes and consider them as a normal bone, you may enter posteriorly, which is quite wrong. In rare situations, there are osteophytes here also. Sometimes you are able to draw an epicondylar axis, that means a line joining both the epicondyles, and what is called as a white side line. That is the line from the deepest part of trochlea to the highest part of the notch, and the bisection point of these 2 lines can be your entry point. But the common mistake in this method is that the trochlea and the notch is not normal. There are osteophytes over here and there are osteophytes over here. So because of that, you may not get the exact point over there. So the best thing to do is to see an X-ray, AP and lateral, and find out what is the best entry point over there. Now, I'm spending a lot of time on entry point because it is important. Because once you get a good entry point and get a good axis, everything else is done by the jig. In clinical practice, what you can also do is trim the osteophyte over here and just a thumb breadth anterior to the PCL attachment can be your entry point. But everybody's thumb is different thickness. So again, go back to the X-ray, AP and lateral, and see the entry point. Once you see the entry point and you go in from there, once you go in from there, you perhaps, what is important here is all these people are very osteoporotic, and the medullary canal is quite broad. A good number of times you may be able to put a nail of almost 11 or 12 millimeter into the medullary canal, but our intramedullary rod is hardly 6 mm thick. So what may happen is the rod, after you have done the entry point, may go either towards the medial cortex or towards the lateral cortex, which will defeat your purpose. The idea is to open the medullary canal and the rod should go right down to the isthmus. Also important is that if you look at the lateral side, the rod may perforate the anterior cortex or may go to the posterior cortex, but it should not happen. It should go right into the center. The idea is that from the center of the lower end of the femur, you go up to the isthmus.